large defect. How much ischemia? 64% of the 25%, so there's quite a bit of ischemia that you and the patient should be concerned about. This patient should probably be revascularized. Sounds like a riot is forming. Okay. All right. Another. So this is a female lady. A lady. So how many of you this patient is abnormal? How many of you think this study is abnormal? How many of you think it's normal? So I'm making you a little paranoid, ain't I? Okay, so you see that at first glance everything looks normal. I mean, this looks beautiful uptake, everything is yellow or white type of thing, and maybe you're used to reading in black and white. I feel sorry for you, but the problem here is in this distribution, which happens to be systemic, you expect the lateral wall to be harder than the septum, but guess what? It's not. So when you compare it to a normal database, you're going to pick up on that. So even though it was difficult visually to see it, you can see either in the polar map or in the images if you are careful to look at it, and it will detect additional normality. So in fact, when we published this, not with sestamibi, but with thallium in circulation back in 1988, you can see that quantification of that lateral wall was a lot more sensitive for the quantitative approach versus visual, and no loss of specificity, at least no significant loss of specificity. Okay, other advances, image fusion. So now the idea is what happens when you combine the physiological functional information of nuclear studies with the anatomical information from CTA. And just to try to go a little fast, this study was read as equivocal, either normal or equivocal. The CTA was read as equivocal also, too much classification here, difficult to tell over here. But when we quantified it and we aligned it, we see that the region of hyperperfusion in black aligns perfectly with the region of the anatomic lesions, and we are a lot more certain in saying this patient does have disease. And in fact, when we look at the multi-center trial from Cesar Santana from our group back in 2009, we get significantly better results, not only to looking at just perfusion, but even better than looking at side-by-side perfusion and CTA. This is an example from Camperley, and this is a patient with myocardial bridging. And then the problem here is it the diagonal or is it the myocardial bridging? Looking at over here, you say it's tough to think that this could be a diagonal all the way here in the anteroseptal wall. But in fact, when you fuse it, you can see that the bridging is not perfusing the region of hypoperfusion, but the diagonal is. And again, similar to what we showed, they also shown that increases the certainty of reading the study. I want to finish with an exciting new technology. New means 6 years. We've been working on this for 6 years, but it's finally getting popular. And this is how in the United States, and I think in Brazil too, we're seeing a lot more patients with heart failure. A lot of the patients that the treatments were good and now they live longer with coronary artery disease are getting into heart failure, and now they're expensive treatments for them, as you know, resynchronization therapy, ICDs, defibrillators, and all kinds of other things. So you know that biventricular pacing is what is called cardiac synchronization therapy, where there are multiple leads that are being placed in the heart, and one of them is being placed in the lateral wall, one in the right side and one in the septum. The question is, so in the United States it costs about $60,000 to do this procedure. A lot of people are getting it, and 30% don't respond to it, don't improve, and in fact, significant number are getting worse. So similar to the issue of improved resolution and improved sensitivity, all this magic technology that we have, we also have the magic technology of improving temporal resolution. And that is, we always acquire 8 frames per cardiac cycle, and It's hard to understand, but I'll tell you, and if you ask me later, the temporal resolution is not given by the number of frames per cardiac cycle, it's given by the number of counts per frame. How you like that one? So what happens here is that we replace the discrete points, and these points are, we're sampling a segment, 8 frames per cardiac cycle, which is the thickening curve for that particular segment. We replace, using Fourier transforms, the discrete points with a continuous curve. So now we've gone from 8 frames to how many? Well, we've already published and validated 64 frames per cardiac cycle. And in fact, if I had an infinite amount of counts, we could go to an infinite amount of frames per cardiac cycle. And we could talk about that someday if you're interested. But we're using here the partial volume effect, the fact that when something is thicker, we get higher counts in the center of the profile. When it's thinner, we get fewer counts, and we do that in a linear fashion. So now we can convert these 8 frames, and you will see into 75 frames that we're using for this onset, and you saw one example before. So this is from a paper in 2005 from my colleague Ji Shen, who has pioneered this technique, showing that it works and that generating normal limits. And here is in a normal patient, and you can see, first of all, the normal perfusion distribution. This is a normal phase distribution. Again, you see early onset of mechanical contraction, late onset. This is textbook normal. And again, you can see how narrow this histogram is. Almost all the segments start to contract at the same time. So this is, again, perfectly normal. Here's in a patient with left bundle branch plot. You can see early, you can see late, and you can see that the distribution had spread quite a bit more compared to that normal patient that I showed you before. And you can see how there is less synchrony in this particular patient. But now the question is, so here's in a patient in heart failure. This is, I believe, class 3 heart failure. Here, you can see how much more desynchronous this patient is. More desynchronous, of course, than the normal, more desynchronous the left bundle branch plot, more desynchronous than the patient with the subendocardial MI. And guess what? After this resynchronization, patients significantly improve in synchronization, both visually and quantitatively and clinically. This patient improved to class 1 heart failure after this successful application. But now look at here, there's 2 different patients. One on the left, class 3 heart failure, ejection fraction of 32% from echo. The other one, class 3 heart failure, ejection fraction of 27% by echo. And now I'm asking you, would you do resynchronization on both, and would you expect both to improve? So let's see what happens here. Well, guess what? The one with the 32% ejection fraction was already synchronized. So we learned early on, if the patient is already synchronized, even though they're in heart failure, every time they try to resynchronize them, guess what? They make every single one of them worse. But if they're desynchronized, like this guy, and you can see this is quite a lot, this patient improved from the 27% ejection fraction to 33, but went from class 3 to class 1. So already showing this is one group of patients that should not be resynchronized with this technique. But beyond that, we've done a lot of work with Bax's group in the Netherlands, and actually we published a paper with Dr. Meneghetti, who's in the room, looking at various applications to this. And we've learned 2 other things. One, you can't place the left ventricular lead into a wall that's infarcted because it's not viable. The electricity doesn't propagate very well. Guess what? Perfusion imaging, that tells you there's an infarction there. So now you see the dysynchrony, the amount of dysynchrony, and you see where the lateral wall is infarcted. And if you're going to put in the lateral wall. The other one is we've also learned, and that was just published in 2011, just recently, probably less than a month ago, again, Bax's group with our group, that it also matters the latest site of mechanical activation with the LV lead position. So now if this is the latest site of contraction, and this is the lead position in the same wall, we say that they are concordant. If this is the latest site of activation, and this is where the lead is placed, we say it is discordant. And guess what happens? When it's concordant, the patient gets better. When it's discordant, the patient doesn't get better. And by getting better, I've been surprised that not only does the ejection fraction improve, like in this patient from 32 to 44, but look at the volumes, was significantly reduced. So the heart reverse remodel back to normal situation, where the discordant, the ejection fraction significantly reduced, the volume increased. Very powerful technique where nuclear is helping in heart failure, and where we're helping now the electrophysiologists direct the treatment. This is true image-guided treatment. So hopefully I've excited you. Hopefully I didn't worry you. But you can see we have a lot of tools available for us. So we have a very bright, not only future or present, and it's for you to take advantage of. Thank you for your attention and for showing up from my lecture.